afternoon, and thank you everyone for joining us for our Healthy Transitions Colorado April 2015 webinar. My name is Penny Cook with Telegen, Colorado's Medicare Quality Improvement Organization, and I'm very happy to be here with you today as we talk about integrated health homes and the Jefferson Center for Mental Health. Healthy Transitions Colorado is run by operating partners, including the Colorado Healthcare Association, Telegen, which is formerly CFMC, the Colorado Hospital Association, the Colorado Medical Society, and Colorado Rural Health Center, and is managed by CIVIC, the Center for Improving Value in Healthcare. Healthy Transitions Colorado is a collaborative effort focused on aligning and accelerating existing efforts to improve transitions of care for Coloradans. Our guiding principle is that by breaking down the silos of healthcare, we can foster true community care coordination across facilities, specialties, and practices. HTC coordinates the tools, resources, and efforts of many partners across the state. We want to keep Coloradans healthy so they can enjoy more of what our beautiful state has to offer. Our goals for this campaign follow the triple aim. We hope to eliminate 8,700 readmissions, eliminate over 34,000 days in the hospital, and save $80 million for Coloradans. If you haven't already done so, we'd like to invite you to become one of our community partners and take the pledge to improve patient care transitions. To take the pledge and learn more about HTC, visit our website at www.healthy-transitions-colorado.org. I have just a couple of things before we get started. The phone lines have been muted and will remain so throughout the webinar. We'll be using the chat feature that's available in the lower left-hand corner of your screen to field questions and allow you to make comments on the discussion. Questions posed to the presenter will be answered during the Q&A session after the presentation. The webinar is being recorded and will be posted to the HTC website, so you may access the information again at any time without cost. So now I'm going to turn the program over to Mindy Clouden. And let me just introduce Mindy. She's the Director of the Office of Healthcare Transformation at the Jefferson Center for Mental Health. She's responsible for providing coordination to the center's healthcare integration program, developing staff, and capacity building and training related to integration. She also serves as a behavioral health integration content expert and provides technical assistance, training, and consultation to primary care and behavioral health providers and other key stakeholders. Before I turn this over to Mindy, we've heard that there may be some people from outside of Colorado on the webinar today. If you're from out of state, we welcome you, and please let us know where you're from using the chat box. Thank you for being here, Mindy. Please take it away.
All right. Thank you to everyone for joining us today. Again, I'm Mindy Clouden. I'm the Director of the Office of Healthcare Transformation at Jefferson Center for Mental Health. And I'm going to be talking with you a little bit about some of our efforts to achieve the triple aim and to really focus on helping people with serious and persistent mental illness and other comorbid chronic conditions to access integrated behavioral health and primary care services and keep them out of the hospital. A little bit more about Jefferson Center. We are a community mental health center that serves the 3 counties to the west of Denver, so Jefferson, Gilpin, and Clear Creek counties. We were formed in 1958 and have been serving the community since that time. And last year we served about 12,000 patients. So it's a pretty large organization with a lot of folks that are receiving care from us. We have about 20 clinics and are also providing integrated behavioral health services in 18 primary care offices, 2 federally qualified health center offices, and 3 school-based health centers. It doesn't look like anyone has typed into the chat box that they're from out of state, so I won't spend too much time on kind of putting Colorado in context, but I do want to comment on the fact that as a Medicaid expansion state and a state that has opted to run its own health insurance exchange, we have now come down to 11.2% of the state being uninsured. But the folks that we see at Jefferson Center and in most of the community mental health centers around the state are still largely uninsured or underinsured. We have about 20% of the population that we see has no form of coverage, and about 50% has Medicaid. So it's a pretty substantial portion of who we're seeing. So let me talk a little bit about why integrating behavioral health and primary care is so important to the population that we serve. I think by now many folks are aware of the kind of stark research that has come out nationally that shows that people with serious mental illness are dying 25 years younger than their counterparts that don't have serious mental illness. And that is even more stark for folks that have co-occurring substance abuse. So for people that have co-occurring substance abuse disorders, they're dying at an average age of 45. And this is largely due to preventable conditions and lifestyle issues. Unfortunately, people with serious mental illness may delay seeking medical care due to fears and other concerns. There are other barriers to them seeking primary care. And some psychotropic medications that they are on may be exacerbating their risk for other chronic conditions. We did some research at Jefferson Center a couple of years ago and found that we had 2,000 adult patients that had Medicaid, so had a payer source, and were in Jefferson County and did not have a primary care provider and had not seen one in several years. And we knew that they viewed us as their healthcare home. We have patients that were coming to us maybe once a month for a therapy appointment. And so we knew that we needed to do something to help make sure that folks were getting the whole person care. It's also important to us to be taking a look at how having a mental illness impacts patients' ability to deal with other chronic conditions. And what this chart is showing you is that for people that have comorbid depression and anxiety with other major physical health care conditions, their cost to the system is dramatically increased. And this is usually not a result of them requiring behavioral health treatment, but rather that without behavioral health treatment, the cost of treating their physical health condition is much higher. So it's essential to the triple aim that we be looking at expanding integrated care. Just a little bit about when we're talking about integrated care, what are we trying to achieve? Certainly increasing access to care. So for the patients that we see within the community mental health center world, many folks have different barriers to accessing primary care. Things like transportation, the amount of time that it may take to go to appointments, fears and anxiety about being seen by a doctor. All of those things can prevent the patients that we see from going outside of our clinic walls. We also wanted to improve their overall health and wellness. And knowing that by providing integrated care, you're better able to look at how physical health conditions and mental health and substance abuse conditions interplay, how they impact each other. We wanted to increase communication across providers. So we know that often a primary care provider will refer someone to us. There might not be a release of information sign. There might not be any care coordinator who's ensuring that there's communication going on between our provider and theirs. And it ends up feeling like a black hole. And that's a concern in terms of being able to fully address the healthcare needs of the clients that we might both be seeing. Reducing overall healthcare costs, as I showed with that earlier slide. We know that integrated care can have a significant impact on keeping people out of the hospital, keeping them healthy, and getting them the support that they need to more fully manage their conditions and take self-management responsibilities. And then lastly, we really wanted to improve patient and provider satisfaction. So a lot of patients have been very vocal about how welcoming they are, how much they welcome receiving all of their care within one place and having their providers know what's going on with them across all of their different healthcare dimensions. So again, I think the bottom line being that integrated care is really the direction that our healthcare delivery system needs to go in order to achieve the triple aim of improved population health, improving the experience of care for our patients, and reducing the overall per capita cost. So I'm going to move into talking with you a little bit about one of our specific programs called Union Square Health Home. We wanted to create a health home for people with serious mental illness and other chronic conditions. And In order to do this, we pursued a grant from SAMHSA, the Primary Behavioral Healthcare Integration Grant, which we're now 2.5 years into. It's a 4-year grant. We worked together with our very close partners at Metro Community Provider Network and Arapahoe House to create essentially a one-stop shop, or as close to a fully integrated clinic as we could, providing wellness services, care coordination, behavioral health, physical health care, and access to community resources and supports that address the social determinants of health. Just a little bit more about what Union Square entails. Based on the SAMHSA-HRSA levels of integrated care framework, we are a level 5 integrated mental health, substance abuse, primary and preventive care organization. We're providing behavioral health services through Jefferson Center, substance abuse treatment through Arapahoe House, and primary care through Metro Community Provider Network. But to the patients, it feels very seamless. They see their provider as Union Square Health Home, and that's really important to us. We're really working hard to make sure that that is as seamless as possible for all of our patients. We also invested in a peer wellness coach because we knew that a lot of the patients that we see have not had physical activity, they have poor nutrition, they may not be very accustomed to goal setting when it comes to their own health. And working with someone who has experienced their issues, who has lived experience with mental illness, is very important. And having an example to look to, someone that has been able to achieve more whole health and work with them to set their own goals, is important to the success of our program. Care coordination is also essential. Our care coordinators work to make sure that patients, again, have as seamless an experience as possible, that they're fully aware of the vast array of services that we offer through Union Square Health Home, and that they work with patients to break down any barriers they may be experiencing to accessing care. We have labs done on site with an arrangement with Quest. We offer access to specialty care, benefits navigation and ancillary services, so again, helping folks that may need access to employment or housing, food banks, etc. And we work with folks to do chronic disease self-management using both the Stanford Chronic Disease Self-Management Program and other evidence-based practices. We have an advisory board that's working with us that includes consumer representation, and that consumer voice is very important as we continue to grow and expand Union Square Health Home. And it's also important to ensure that the partnership among the organizations is rich and that we're all moving towards a common vision. We're formally evaluating the program, and I'll talk a little bit with you about some early results. And one of the things that we've really invested a great deal of time and energy into is making sure that we have exchange of health information electronically. So we're using continuity of care documents and using that as a way of kind of working around the fact that we have multiple electronic health records. A little bit about some of the universal screening and health indices that we're gauging. As I mentioned, people with serious mental illness are dying 25 years younger than their counterparts, and that's largely due to preventable conditions. So we think it's very important that on the physical health side, we are consistently monitoring body mass index, blood pressure, waist circumference, breath, cholesterol and triglycerides, fasting glucose, and hemoglobin A1C. And so all of these are collected at the first appointment and again at 6 months. So we're able to gauge where folks are. On the behavioral health side, we're doing a screening, brief intervention, referral to treatment, which is substance abuse screening. And anyone who is screened positive on their SBIRT may be given an audit or a DAST, depending on if they're using alcohol or other drugs. We're also using a PHQ-9 to gauge depression. And what's interesting about that is that even though we're a community mental health center, we may have a client who's diagnosed with schizophrenia who also has substance abuse, and adding the PHQ-9, and also has depression. So adding the PHQ-9 has been a really important tool for us to, fully look at where the patient is at that point in time. We're also measuring for chronic pain and have developed our own tool that we're using to gauge where people are in terms of pain management. We use the CCAR, which is required of all community mental health centers in Colorado. And finally, we're using a quality of life measure, which is important to gauge where people are feeling about their own success and how they view what they're able to do in their own life and what's important to them. One of the key pieces that I want to spend a little time talking with you about that we're doing at Union Square is collaborative care planning. And collaborative care planning is really what makes Union Square a more fully integrated program as opposed to a co-located program. Collaborative care planning allows us to see the person as a whole so that we're not just dealing with physical or behavioral health. It's a way of making sure that all of the providers that are working with the patient are in good and regular communication with another, talking together about how, for example, depression may be impacting someone's diabetes and diabetes may be impacting someone's depression. And it's also a way for us to bring in essential elements from each of our respective electronic health records to look at a shared common care plan. So what we do for collaborative care planning is once a week, our providers spend an hour talking about the patients that have the most complex health issues. And when I say our providers, we're pretty inclusive about that. So we have not only the primary care provider, the MA, and the psychiatrist. We also have the therapists, the substance abuse counselors, the care coordinators, our members of our navigation team, and members of our wellness team. So really anyone who's interacting with a patient is invited to participate in these weekly meetings. And they come. And they come ready to talk about the complex issues that our patients are facing. The care coordinator works to ensure that we're identifying the patients with the most complex needs we really need to be spending the time on, because as you can imagine, we have a fairly limited time with that 1 hour a week. And then the major health issues within each of the domains, the physical health domains, the substance abuse, mental health, and wellness are all brought into one common treatment plan. A little bit about what we're seeing so far. So some early outcomes based on our first 2 years. 25% of patients were identified as being at risk for metabolic syndrome. Metabolic syndrome is a group of indicators that are considered together. So they include things like blood pressure, waist circumference, plasma glucose, HDL cholesterol, and triglycerides. And patients who are at risk for 3 or more of these are considered positive for metabolic syndrome. Metabolic syndrome is considered one of the greatest risk factors for people with serious mental illness, and was identified early on as one of the things that we really needed to focus our efforts around. We do 6-month reassessments, and on our first cohort of patients to reach the 6 months, 83.5% of those folks who had been identified as at risk of metabolic syndrome were no longer at risk. So this is some pretty significant improvement. We're also impacting behavioral health. So what we see here with our PHQ-9 is that overall, patients averaged a significant reduction in depression severity scores from 13.4 at baseline to 11.1 at 6 months. And importantly, suicidality also decreased from 41.3% at baseline to 30.3% at 6 months. And that's absolutely essential to us. We really take very seriously the idea that we need to make sure that we don't lose any of our patients to their own hand. Another thing that we are gauging is the impact of Union Square Health on overall healthcare costs. Again, getting back to the triple aim. And the data that's available to us to do this is somewhat limited. So for example, right now, we only have access to behavioral health information when it comes to hospitalizations and emergency department use. So we're working to get a more comprehensive picture. But what we are able to show is that at this, at the 2-year point in time, the 2-year annual report was able to find that there was a reduction in hospitalization, there was a reduction in use of the detox facilities, significant reduction in the use of jails, and also in emergency room visits. So we do know that Union Square Health Home is already having some really measurable impact. But really what makes this all worth it is the stories of the patients who are sharing with us that their life is changing significantly. So I just want to share one of those with you. I'm going to talk with you about a man who I'll call Ron, who came to us, did not have a primary care provider, and had not seen one in many years. He had been in and out of multiple emergency departments and psychiatric hospitals. He had both complex psychiatric disorders and a number of different physical health issues. And these were all complicated by his drug use. So his drug of choice was methamphetamine, but he also drank alcohol. And he had all kinds of physical health issues that were resulting from that. He was at risk of hepatitis C. He had hemorrhoids, elevated liver enzymes. He had a poor appetite, poor diet, placing him at risk of diabetes. He had some swelling in his legs, sores on his arms from IV drug use. He had poor living conditions and had some bed bugs as a result of that. And as you can hear, this was all very complicated, and all of these issues were too much for him, and he didn't feel like he could do anything about them. We immediately got him connected to all of the services that we had available at Union Square Health Home, and began to see immediate improvements in his overall attitude and approach to his health. And since being treated in the integrated clinic for the past year, he's had huge improvements in his physical health. He's been sober for over 1 year. He's right now actively working on quitting smoking. He has had real improvements in his mental health and feels a greater sense of clarity about what he needs to do to take care of his own health. There's been a large decrease in his own emergency room visits. And he's now meeting with a dietitian to learn how to eat more healthy. We're also working with him to connect to his spiritual life, which was something that he identified as being important to him. So when we think about folks like Ron and how dramatically his situation has changed, this is really what makes doing the work that we do all worth it. So while Union Square was kind of the focus of what I was asked to present, I did want to talk with you a little bit about some of the other work that we're doing at Jefferson Center around integrated care. So I mentioned that we are currently in about 18 different primary care practices, private practices. These are largely serving insured patients, and we do this through a program that we call Solutions Now. This is really a co-location program. And in this program, we are placing Jefferson Center employees who are licensed behavioral health clinicians into a primary care practice. And we do all of our own billing. So there are no same-day billing issues. And we also have found that a number of primary care providers really like this because they're not accustomed to or well-informed about how to do behavioral health billing. The practice provides all of their referrals and scheduling assistance and the office space to our clinician. And then the clinician is providing traditional mental health therapy, 40 to 60 minutes visits. And that is largely driven by the fact that, one, it was identified as a patient need, but also, two, this is what we're able to be paid for. So we like to try to make the behavioral health provider available to consult on a regular basis with the primary care provider and their team. But unfortunately, the way current payment methodologies are right now, there is no payment available to support that time, that time spent on provider-to-provider consultation. We open the clients and do a full intake into the Jefferson Center system, and we chart in our own electronic health record, although we have access to some electronic health records in the primary care offices and give them progress notes that they scan in. Another example is a slightly different model of providing behavioral health services at Metro Community Provider Network in their clinics in Jefferson County. And this is a little more of a fully integrated model where we're doing what is more characterized as primary care behavioral health. The practice provides not only the referrals and scheduling assistance, but also warm handoffs in real time. And the behavioral health providers are not doing full-blown long-term therapy. They're doing instead a brief consultation model, mostly focused on the physical health issues and behavioral aspects of physical health issues that are involved with helping a client to manage their own chronic illness. When patients are identified as needing more in-depth behavioral health treatment services, they are then referred to Jefferson Center to be served in one of our clinics. Another example I wanted to share with you all is more of a collaborative program. We are part of the Jefferson County Hotspotting Alliance. And this is a group that grew out of several years ago, about 3 years ago now. We had a grant from the Colorado Trust, at Jefferson Center had a grant from the Colorado Trust to hold a series of convenings that were focused on the healthcare needs of our community. And we invited a number of different providers and organizations to these meetings to talk about what were the priorities, what were the unmet needs, how did we see healthcare reform impacting the community, and what were some opportunities for us to enhance collaborations. From that work, we identified that one of the greatest concerns in the community was reducing inappropriate emergency department utilization and really focusing on those 5 to 10% of the population that was costing the system the most, inappropriately using the hospital when they should be accessing primary care and primary behavioral health services. So a group of us came together to form the Jefferson County Hotspotting Alliance. The key members are CCHA, which is the Regional Care Collaborative Organization in our region, Metro Community Provider Network, Arapahoe House, Jefferson Center, Lutheran Medical Center, and St. Anthony's Hospital. And collectively, our 6 formed the Jefferson County Hotspotting Alliance. We're currently also in discussion with the Jefferson County Public Health Department about joining the alliance. We decided to do a self-funded project with a robust evaluation, with the idea that if we could prove that by providing care coordination and enhancing access to primary care and behavioral health, we could reduce inappropriate hospital and ED utilization, that we might be able to get it funded in a sustainable way for the long term. So the primary goals of the Alliance are to reduce emergency department utilization of the top 5 to 10% high utilizers at the 2 hospitals. We also really want to increase patient knowledge and skills to manage and follow through on their own healthcare needs. And so our care coordinators are working with the patients to do education around when do you go to primary care, when do you go to behavioral health, versus when is it appropriate to go to the emergency department. And how do you access chronic disease management training if that's what you need. We're also looking to demonstrate a reduction in overall ED costs through this community-based intervention. And so the way that we're doing that is we're actually using hospital data to help us measure if someone was to come to the emergency department, what would the cost of that visit be, as opposed to what is the cost of them going to the primary care provider. So we have two FTE care coordinators in place now. One started about 6 to 8 months ago, and the other has just come on in the last month. So it's too early to have any evidence to share with you all yet. But we do know that 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 patients are reporting to us that they feel much more that they feel much more aware of what resources there are out there. We've gotten all of the patients we've seen so far connected to primary care, and all of the patients we've seen so far have needed mental health services as well. So I alluded to this earlier, but really the #1 barrier to sustaining the work that we're doing and the work that many of our colleagues are doing around integrated care is the current payment methodologies. So there's been a real over-reliance on grant funds to facilitate this work. And some of the specific things that are that we have to rely on grant funds for are care coordination, particularly in the community mental health center setting. There is very little support in current payment methodologies for wellness support and for health coaching. And as I mentioned, the time that it takes for providers to sit down with each other and really do that collaborative care planning, that's one of our biggest gaps, I think, in doing more fully integrated care across the state and across the country, is we have such an over-reliance on with the primary payment methodology still being fee-for-service, providers are forced to see more and more patients and spend less time thinking about the quality of care and the experience of care. And we need to get off of, we need to get away from volume-based payments so that providers are able to take the time that they need to really look at the whole person. So this is a slide I actually borrowed from Civic, so thank you, Civic. But it's just showing the continuum of healthcare payment models and methodologies. And I think there's increasingly a push for us to move towards bundled payments and global payments, which will account for the whole person needs and will not separate out physical health from behavioral health, because we know that that's a false dichotomy. So we have ample time for questions and discussion, and I would love to hear what other folks are doing and what questions you may have. So I think we need to type questions into the chat box, although it looks like there's a fairly small group. If you did want to unmute phone lines.
No, we're going to keep them muted at the moment, but I know Penny has a question.
I do, and if anyone else has questions, please type them into the chat box, or anything that you're doing related to the type of behavioral health and medical integration that Mindy's talking about. Mindy, thank you so much. And my question is about Union Square Health Home. So I'm wondering how many patients you serve there, and how is that health home available to patients?
Sure. So we're currently at around 450 patients. By the end of the year, we expect to be at 600 patients that are enrolled in the health home. To be enrolled in the health home, that means that the patient agrees to receiving all of their care within that facility. So they're receiving their behavioral health services, their primary care services, and any other wellness services that they may be needing within Union Square, as opposed to other Jefferson Center locations or other MCPN locations. And they also agree to having all of the metrics that I showed before collected at intake and at reassessment. The way that patients end up at Union Square or become enrolled in Union Square is when they are provided an intake at Jefferson Center, one of the things that we do is we ask, do you have a primary care provider? And if they do not have a primary care provider, we ask if they're interested in enrolling in the health home. And I should clarify that it's only for adults who live in Jefferson County. And so, some of it is a self-selection process, and some of it is based on the geographic convenience. Are they willing to be seen and receive their care? Is it convenient for them to receive their care at that facility? But much of it is based on, what needs are they presenting with at their intake.
That's great. That's a high number of patients. So thanks for that. And we do have a question in chat, Mindy. Do you have any data on physical outcome measures at Union Square Health Home?
Well, the data that I showed earlier related to, let me go back to it, related to metabolic syndrome. Here we go. So we had 25% of patients were identified as having metabolic syndrome, and 83.5% of these were no longer at risk. So that means that they had improvements in blood pressure, improvements in diabetes management, or if they were at risk of diabetes, they had more limited risk, improvements in BMI. Those are all the things that go into identifying if someone is at risk for metabolic syndrome.
Are there any other outcome measures on the physical side of things besides the metabolic syndrome that you're measuring at this point, or that you will be measuring in the future?
Let me go back again. So here are all of the things that we are measuring, and we will have more data in the future. Again, the Union Square Health Home has been operating for just over 2 years, and so that's the data that I have in front of me to share with you now. But I think the other thing that's really important to point out is that of those 400-some patients, they were all people that did not have a primary care provider, and most of them had not had a primary care provider for some time. So, in addition to looking at what measurable outcomes do we have, it's also a pretty significant outcome to be able to show that someone who was not receiving any care is now receiving care.
That's definitely true. We have another question in chat. What level of training is suggested for your care managers? Because they seem to be quite clinical in their involvement in care planning, health coaching, and coordination between specialists.
Yeah, I think that's a great question. And, it seems like a lot of people are kind of struggling with what are the right credentials for a care manager, and what exactly, when people are talking about care management versus care coordination, what are they really talking about? What we have done is we have care coordinators that are RNs, and we also have care coordinators that are social workers. And so we don't, it's not necessarily one or the other. It's more a skill set and a willingness to work in a flexible way and to work with many different kinds of providers. We think it's really important that our care coordinators are also interested in and willing to and able to work with the serious and persistent mentally ill population, that they're comfortable working with that population, and that they're, as I said, comfortable working with both behavioral health providers and primary care providers, because they really serve as the linkages and as the, they're kind of the glue that holds the whole thing together.
Great, thanks, Mindy. We have another question in chat, and I guess the question of whether you have these measures yet related to the patient management measures and if they've changed for those involved in the program. And then another question regarding that, how have the measures changed on the Stanford self-management tool, the quality of life measurement tool, and any other assessments like that?
I'm going to have to get back to you with that information because I can't, I have it in my computer, but if I start looking, I think you'll all see my screen, and you'll see everything on my computer. So I don't have any other data to present to you at this moment.
But those are things that you are measuring, however.
Yes, I mean the SF36 we are using, and so we have some data on how SF36 results have changed from intake to reassessment. And the Stanford self-management, so the Stanford program is a 6-week evidence-based chronic disease self-management class. It's in a group setting. And so at the end of the class or group, the participants evaluate their own level of, their own sense of their ability to manage their conditions, to talk with their primary care providers, and to reach out for social supports.
Okay, great. another question. Mindy, who manages the new workflows in the practices to accommodate all of the assessments? And are specific practices, I'm trying to read the question, coaches needed?
That's a great question. We're constantly doing workflow reassessment and kind of ongoing continuous quality improvement so that we're looking on a really regular basis about what needs to be tweaked and how are we making sure we're not duplicating efforts between our health coaches and our care coordinators. And that weekly collaborative care planning meeting helps with that as well, in addition to the times that we schedule to actually sit down and work on workflow. We have not had a practice coach, although we do have technical assistance available to us as a PBHCI grantee. We have technical assistance available to us through the Center for Integrated Health Solutions.
Great. And Mindy, I have another question again. It's Penny. So related to the funding that you have for this project, how many more years of funding do you have, and is there a sustainability plan after that?
Another great question. So we are 2.5 years into a 4-year grant for Union Square Health Home. And in terms of our work on sustainability, while we are hoping that payment reform sustains the program and that the work of the state innovation model, and the efforts around payment reform there can ultimately benefit Union Square and other integration efforts. We're also, kind of at the more immediate practical level, trying to look at what are some things we can do in the short term. So for one thing, we, about a year ago, expanded substance use disorder treatment benefits were added into the behavioral health organization contracts. And we are starting to look at, accrue our encounters to the BHO contracts. That will help augment some of the grant money that has been supporting substance abuse services. We recently became eligible as a primary care medical provider under the Accountable Care Collaborative, which has a, I'm sure everyone on the phone knows this, but it has a very minimal dollar amount, no more than $4 per member per month to support care coordination. So that will be that will help with sustainability. And then, of course, we're constantly looking at efficiencies that can be made so that when the grant ends, we're really able to look at how do we contain our costs.
So it sounds like the planning is already happening for that sustainability piece. Are there any other questions that anyone would like to put in chat? Well, Mindy, thank you so much for sharing your work with us, and thanks to all of you for joining us. We really hope it's been a valuable use of your time and that you'll be able to use the information to further your own care transition efforts. Just to remind you, the webinar has been recorded, and Mindy, we have one more question, if that's okay.
Yeah, that's great. There's something about how you treat your employees that then translates to the employees being able to deliver innovative care to patients. That's another great question. I think one of the first things I would say, and I've worked here for about 10 years, so I think it's a great place to work myself. But, one of the things is that we really have an organizational value around taking care of ourselves. We know we can provide the best patient care if we are taking care of ourselves. And so we do things for employees, like there is a robust employee wellness program that has a number of different incentives tied to it. We offer a wellness hour once a week, so a 40-hour week is really a 39-hour week if you are able to take advantage of it and use that hour to go to the gym, get a massage, watch your children play soccer or whatever it may be. I think we also are a fairly we believe in transparency, and we're an organization that really promotes leadership at different levels. And so, I think that keeps people here too, because they know that they can have a voice.
Well, thank you, and congratulations on that honor from the Denver Post.
Thank you. It was the 3rd year in a row, so that's pretty cool.
Wow. Any other questions that people would like to put in chat?
And if there is anything that you want to follow up with me personally around, or anything that I said I didn't have, I didn't have in front of me today, but you'd like me to look into, I'm going to go back to the slide that has my contact information, because I'm very much open to follow-up conversations.
Well, that's great, and thank you again, Mindy, and thanks for everyone that's been on the webinar. And just a reminder, the webinar has been recorded and will be available on the HTC website in just a few days for your own use or to share with colleagues. So I hope everyone has a great afternoon, and thanks again.
Bye.
Great. Thank you.